think the most important statistic is that the heaviest burden in terms of known cases of acute Vivax malaria indeed occur in the Asia-Pacific region, with the heaviest burdens being India, Pakistan, Myanmar, Indonesia, Papua New Guinea, and some others. So it's a quite significant and heavy piece of the global burden of Vivax malaria. The Americas have a problem. It's the dominant species there. Africa has well, it's a nuanced problem, but they also have to deal with Vivax malaria. But in terms of endemic, high-risk Plasmodium vivax, it is an Asia-Pacific problem. We believe there is significant underreporting. If we look at, for example, if we look at the World Malaria Report, what they're counting is estimates of clinical attacks of this species and Plasmodium falciparum. And P. vivax tends to pale in comparison to Plasmodium falciparum. But what we're beginning to appreciate in places across Asia and elsewhere is that there's a very significant asymptomatic and latent reservoir of infection of Vivax malaria. So when we look at case numbers, we shouldn't be overconfident in terms of the relatively low numbers, because the numbers of people actually infected are much higher. And this is very significant when we talk about an agenda for trying to eliminate this species. Well, in terms of diagnosis, it's a significant challenge for the reason I just alluded to, and that is that most of the people infected are not actually ill. They may become ill later, maybe not, but they're transmitting the infection. And the treatment of these people the diagnosis and treatment of these people is a very significant challenge. Add on top of that, the drug that we need to treat latent Vivax malaria with are the aminquinolines. These are the only drugs we have. And these are quite dangerously toxic to people who have a very common inherited abnormality, an enzymopathy called glucose 6-phosphate dehydrogenase deficiency. If patients have that deficiency, and on average about 8% of people in malaria endemic countries do, that's a very high number of people we're talking about, they're accidentally dosed with therapeutic doses of these drugs, their life is in danger. They may not survive if they don't have access to acute care for their hemolytic crisis, which would result from giving that treatment. So finding the people who are infected is a big challenge. Treating them properly is a deeper challenge. We know that in Southeast Asia and Indonesia in particular, but also Papua New Guinea, Vanuatu, Solomons, that most Plasmodium vivax is resistant to what has been the frontline treatment for acute Vivax malaria for decades, a drug called chloroquine. So chloroquine-resistant Plasmodium vivax is quite common. It's so common in Indonesia that we can't use the drug ethically, not even in research. It's less common, but present in places like India, Myanmar, and the Mekong subregion. So that is a problem. Fortunately, the artemisinin treatments that are now frontline for P. falciparum, those also work with chloroquine-resistant Plasmodium vivax against the acute attack. The problem, again, and its challenge is that we have to treat not only the acute attack, but we have to treat latency as well. And the combination of drugs that we use, we can't simply freely interchange, okay, chloroquine doesn't work, let's use this ACT with primaquine or tafenoquine, the new acetaminophen. It's not that easy. It's much more complicated than that. And that's a challenge. So chloroquine-resistant Plasmodium vivax makes treating radical cure, that's against the acute attack and the latent phase, really challenging for us. And I should add another complication, and again, it relates to the acetaminophen and treating that very important latent reservoir. We're finding that drug, that class of drugs, has to be activated by the human host in order to work. In the case of primaquine, it's activated by a cytochrome, P450-2D6, which is a highly polymorphic enzyme. And we're finding in Indonesia, for example, about 12 to 15% of people properly treated with acetaminophen will fail that treatment. And almost all of those treatment failures are due to having a form of CYP2D6, which does not activate the drug. So in terms of treatment failures, we're more worried about activating the drug than we are parasite resistance in the latent phase. Well, I've explained how problematic the current drugs we have are. They're dangerously toxic. They're given at doses which are very, very near the limit of tolerance. And they're requiring activation by cytochromes. These are all liabilities. And we can't use them in pregnant women either, by the way, which is a terrible limitation because pregnant women and their fetuses are vulnerable to these infections, and we can't properly treat them. So I think the opportunity to find classes of drugs that kill hypnozoites without all of that baggage would be an incredible breakthrough. It might even enable us to eliminate this parasite. But the tools we have right now are so complicated for all the reasons I've already explained that we desperately need an exploration of classes of hypnozoic anti-relapse drugs. And fortunately, over the past 10 years or so, there have been advances with high throughput screening using ex vivo human hepatocytes and parasite development in them to try to identify these drugs. So there is progress on that front, and hopefully somebody will have a breakthrough and we can get much better therapeutics against this parasite. Well, I think that's a misunderstanding. I think Vivax malaria has not recently changed to become more virulent. I don't believe that. I think what has happened instead is that for decades, we, the community that studies malaria, misunderstood Plasmodium vivax. We were led to believe that it was benign. But actually, if we go back and look at the literature from the early 20th century, there was a period in the 1920s, 30s, and into the 40s where patients with neurosyphilis would be deliberately given malaria as therapy for their neurosyphilis. okay? Now, untreated neurosyphilis is invariably fatal. And the malaria treatment for it, if it was not a severe attack, a series of attacks actually, the therapy would not work. So the clinicians managing these neurosyphilis patients took a lot of chances. And in fact, Plasmodium vivax was the treatment of choice because they believed it was not that dangerous. But in fact, looking at the records and the firm experience with those infections, it turns out that 5 to 15% of those neurosyphilis patients did not survive the malaria treatment. So there's a very good record in scientific, clinical, that inadequately treated Plasmodium vivax and Plasmodium vivax for neurosyphilis therapy was by definition inadequately treated. It was an infection allowed to run its course, and it often killed patients. And it's still doing it today. And when we look in hospitals where patients have limited access to limited quality care, mortality due to Vivax malaria is not at all uncommon. Where it is uncommon is places like Singapore and the United States, where patients have quick, easy access to very high quality care. In that setting, it's less dangerous, right? But let us understand that the burden of malaria is in people who do not have access to care. It's out in the rural areas where it's hard to get to clinics, it's hard to get to treatment. Hospitals are far away. So when we look at Vivax malaria in inadequately treated, very sick patients, that's more like the Vivax malaria that occurs in most patients. So I don't believe this is a new trend. I believe this is inherent in Plasmodium vivax. We were deceived by the fact that Plasmodium vivax in our bloodstreams is naturally lower than it is with P. falciparum, the allegedly the malignant. Discovering recently is that Plasmodium vivax has profound tropisms for deeper tissues like the spleen, the marrow, and perhaps even the extravascular spaces of liver. So the biomass of P. vivax in any given patient, most of it is not in the peripheral blood. It's elsewhere. And if we can't see it, it's causing harm that we don't realize and we don't understand. And we're finally beginning to understand it, that this parasite is not intrinsically benign. It never has been. And it deserves the respect of a dangerous pathogen, which is what it is. Well, I would say to young scientists, I'm very unpopular for this point of view, but I'll say it anyway. I think a lot of the talk about the elimination of malaria from the Asia Pacific and other places is overly optimistic. I think it makes us happy. It gives us something to aim for. That's all good, but we shouldn't believe that we're within years of a world or a region that's free of malaria. I think malaria in the Asia Pacific, Plasmodium vivax in particular, with the tools we now have, because they're so poor, I don't believe we're going to eliminate malaria by 2030, which is what we read. I think that scientists who want to pursue research in malaria will have a future. I'm sorry to say, I mean, it's glum talk, but I think that malaria will continue to be a significant public health problem in the Asia Pacific region for a number of decades to come. And I would encourage young scientists to consider that and to consider stepping into a career path where you specialize in solving some of these wrenching problems with malaria. Do not consider it well beaten. There's no more things to discover. That's just not true. Malaria remains a field with rich discoveries waiting to be made. I've mentioned a couple of them here already. There's more. So young people, you want to study malaria, go for it, because I think it's going to be useful for decades to come.